Assalamu alaikum. Uh, good afternoon, judging committee and all the audience. This is Abdulaziz Aldayel. I'm going to present today a digitally assisted maxillary obturator and speech aid device fabrication as a case report. A removable maxillary obturator prosthesis is a device that separates the oral cavity from the nasal or the antral cavities. And it's used usually to close congenital or acquired defects in the maxilla. The prosthesis enables the patient to perform the functions of mastication, deglutition, speech, but at the same time, it should be comfortable and aesthetic. The case that I have is a male patient, 35 years old, who works as a mechanical engineer. He's married with one daughter, was presented to my clinic with a satisfactory medical history and general health. The facial appearance or the extraoral examination revealed a well-proportioned facial heights. The midline was centered in the center of the face without any obvious or clear asymmetry or deviation. The interpupillary and the intercommissural line were parallel to each other, and both of them were parallel to the horizon. According to the GPT 9th edition, an opening in the hard or soft palate as a result of improper union of the maxillary process to the median nasal process during the second month of intrauterine development is called a palatal cleft. And during the intraoral examination of my patients, I revealed the cleft starting from the first molar area and crossing the soft palate. According to Aramani classification, the patient is a class 3. He had a speech difficulty and never used the prosthesis or being under any surgical repair previously. The frontal view of the occlusion revealed the crossbite in the right side and in the anterior, but since the patient is not eligible for the National Guard orthodontic treatment and he has a stable bite, we decided not to touch the occlusion and proceed with the fabrication of the obturator directly. By the utilization of the CAD/CAM technology, we can reduce the amount of discomfort for our patients, especially these kind of patients who had severe undercuts that making the impression appointments is very hard for such a patients. So intraoral scanning for the dentition and the surrounding structure, so that we avoid taking the impression for the defect, but we had the printed resin model for the dentition. Then we started fabricating the metal framework for the obturator, following the guidelines of the designing principles for such a case with a quadrilateral design. Then the design was printed using cobalt chromium powder and reseated again on the printed model and verified intraorally to verify the passive fit and the intimate contact with the surrounding tissue. After that, the technique that I used, and I prefer to use it for such a patient, is that we can add a triad sheet for the defect area and taking the impression with irreversible hydrocolloid or any impression material that the clinician prefers, only for the defect area without any pickup impression or any. Then after that, I fitted the framework with the impression on the printed model and bead it and box it and put it with a type 3 stone. So I have my altered cast, altered master cast, upon which the maxillary obturator gonna be processed following the conventional processing methods for such a prosthetic solution. The maxillary obturator and the speech aid device was delivered for the patients, and 3 months follow-up was scheduled to evaluate the periodontal health and ensure the hygiene compliance of the patient, to intervene early if the patients fail to keep the clean environment. And in order to get the maximum benefit as a speech aid device, the procedure was relined using the impression wax frequently, just barely to touch the posterior pharyngeal wall. Thank you, and here's my references, and thank you so much.